Good evening, respected Professor Nagaswamy sir and my dear students. I welcome you all to another session of RAISA online DNB academic activities today in the WebEx platform. As a continuation of last week's session, we would request Professor sir to go ahead with applied anatomy and physiology chapters in anesthesiology. Over to students and Professor sir. Thank you, sir.
Thank you. Good evening. And we stopped at the discussion of the various cardiac reflexes, the question which is asked in the examinations. And in continuation of that, I'll just share my screen with you. Hope it is visible.
Yes, sir.
So we'll continue with control of cardiac function, how the heart's contractility function is maintained. So the question here is, how is cardiac function controlled? What are the factors which control the activity of the heart or cardiac function? Can you answer? Vidya, Sanjuta, Isha, anyone can answer?
Hormonal control, physiological control.
Hormonal control.
Neural control.
Neural control, hormonal control. Has the heart got any intrinsic activity of its own? So the first
No.
thing is the intrinsic conduction system, heart, originates from the rhythmic pacing of the discharge from the SA node itself. SA node has got an intrinsic, even if you cut the heart and put it in the bowl, all of you would have done your frog experiments in the, as a lower class students, isn't it? The frog's heart, when you try dissect it and put it in the dissection board, even after denervation and removal, it keeps beating for some time. So that is the basic intrinsic activity, the SA node, which itself trigger the normal activity of the heart. But that alone is not enough, because why the intrinsic activity is not sufficient? The SA node has got its own method. We saw in the last class about the SA node action potential and the myocyte action potential, the difference. No? There is no need for any trigger to come and start the action potential, unlike the myocyte, where it has to receive the impulses from the SA node or the AV node. Then only the action potential will start from the resting phase. Whereas in the SA node and the AV node, you have what is called the automaticity. Automatically, there is a discharge and depolarization and repolarization taking place. So why this intrinsic activity alone is not sufficient to maintain the cardiac function?
It cannot meet the body's demands.
That is a very, very important point. It has to supply according to the demand and the conditions. Okay, when you are doing exercise, you will have to get more blood supply. When you are afraid, you will get your heart beats more. So there is a control from other systems also. Okay, so that is the reason why it cannot survive on its own intrinsic activity alone, right? So all of the components of the intrinsic conduction system have autorhythmic cells to maintain the spontaneous depolarization without any need for external stimulation. But in the absence of extrinsic neural or humoral, SA node pacing would not be, there will be an inherent rate of about 100 beats per minute. The heart rate and cardiac output, however, must vary in response to the needs of the body cells for oxygen and nutrition. So in order to respond like that, to satisfy the demands or the request, The heart rate and contractility are regulated by mostly autonomic nervous system, then hormones and other factors. Okay. So there are two things. One is the intrinsic activity of the conduction system. The second is the extrinsic activity in the form of ANS, hormones and other factors. Okay. So this is how the control is taking place. Now, when we talk about the ANS, what is the role of ANS in the control of cardiac function? How does the autonomic nervous system control our cardiac function? What are the components of autonomic nervous system? Parasympathetic and parasympathetic. What is the role of sympathetic nervous system in the heart?
It increases the
Inotropy, chronotropy, both chrono and inotropicity. Okay. Whereas parasympathetic
it decreases both.
decreases the heart rate. Okay. So that is what you have to do. So ANS can regulate heart rate, blood pressure, rate of our respiration, body temperature, sweating. All these functions are controlled by the ANS, including gastrointestinal motility, secretions from the various glands, and other visceral activities. Out of this, the ANS function continuously occurs without our conscious effort. However, ANS is controlled by centers located in the spinal cord, brain, and hypothalamus. So this is a very, very basic outline of the ANS activity and its control. Now coming to this, which nerves of ANS have effects on cardiac function? We all know that parasympathetic and sympathetic have the effect on the cardiac activity. So what are the root value or what fibers of the parasympathetic or the sympathetic supply the heart? Which nerves actually supply?
T1 to T4 sympathetic ganglia.
Very good. T1 to T4 sympathetic.
Superficial and deep plexus.
Yeah, okay.
Then the vagus nerve as the parasympathetic.
Parasympathetic, excellent. So if you see this picture, you have the sympathetic fibers arising from T1, T2, T3, T4. These are called cardio accelerator fibers, which pass through the sympathetic ganglion and supply the heart, and their transmitters are norepinephrine, and it acts on the SA node, AV node, and also on the myocytes. So RA, LA, LV all are supplied by the sympathetic nervous system, and the action is mainly chronotropy and inotropy. Whereas the parasympathetic control is achieved from the medulla through the vagus nerve, and the transmitter substance is acetylcholine, and it acts again only on the SA node and AV node. And the function of it is decreasing the heart rate or decreasing the chronotropy. Okay. So this is how the nervous control takes place. What are the neurotransmitters and receptors involved in the ANS control of cardiac function? We have already given in this picture and seen what is the neurotransmitter here.
Preganglionic acetylcholine and postganglionic norepinephrine.
And acetylcholine.
So the receptors are like to be classified as like this: the alpha 1, beta 1, beta 2, and muscarinic. So for the sympathetic, you have three receptors: alpha 1, beta 1, and beta 2. Where is alpha 2 located?
Central presynaptic ganglion. The central presynaptic receptors.
Central in the nervous system. Then where else are alpha 2 supplies? Where do you give alpha 2 agonist as inhaler or by inhalation route? Pulmonary smooth muscles. Okay. So in the nervous system, you have three main receptors: beta 1 to increase the activity on the heart, mainly inotropy and chronotropy. Beta 2 on the smooth muscles of the vasculature, and the other cause vasodilatation. Alpha 1 supplies vasoconstrictor fibers in the vasculature. Okay, so these are the three sympathetic receptors, and acetylcholine effect or parasympathetic effect is mainly through the muscarinic M2. There are isoforms which are M1, M2, M3. There are up to several. Commonly, 5 forms are there: muscarinic 1, 2, 3, 4, 5, and they mainly cause vasodilatation. So these are the receptors and their function, and the transmitter substances are mainly norepinephrine for parasympathetic and acetylcholine for parasympathetic. Okay, so this is another basic point which we have to remember for all our examination purpose as well as day-to-day function, so that you can remember in septic shock when there is a profound vasodilatation, which drug do you use to improve the blood pressure?
Noradrenaline.
Norepinephrine, NORAD. All of you would have used it. Okay, so we must know when to use NORAD, when to use epinephrine, when to use dopamine, when to use dopexamine. So all these drugs we have to be aware of, so that we can use them appropriately in the setting to improve the cardiac function. Now, to recall about the signal transduction in both beta adrenergic and muscarinic receptor stimulation. Do you have any idea how the signals are transmitted in these receptors when they are stimulated?
Beta agonist usually follows adenyl cyclase and the GS subtype pathway and increases cyclic AMP.
Very good.
There will be a calcium channel, calcium mediated channels activation will be there. So this
Very
can
good.
induce a chronotrophy and inotrophy. On the other side, there can be a protein kinase activation from the calcium sarcoplasmic reticulum. Through that, vasodilatory action can occur. This is beta agonist. When it comes to alpha agonist, it follows GQ subtype pathway, which is calcium cadmolane complex mediation, and thereby it stimulates a vasoconstriction.
So they are called G protein coupled receptors. Okay, that is the first answer. Signal transduction occurring in beta adrenergic. As there is also part muscarinic receptor stimulation is also asked. Both are G protein coupled receptors. Okay, so and among the G protein receptors you have GS, GI, and GQ receptors. GI is stimulatory, GS is stimulatory, GI is inhibitory, and GQ is through the inositol phosphate system. Okay, so if you see this picture, you will be able to understand that acetylcholine is the transmitter for muscarinic system. So outside the cell membrane, there is a receptor where the ligand has to come and occupy itself. For the sympathetic system, it is norepinephrine, which we saw in the earlier slide. So it has, if sympathetic system is stimulated, norepinephrine is released, and that will come and occupy the ligand site here on the exterior of the cell. This is extracellular space, and this is intracellular space. So once this occupies here, it stimulates. This is the G protein. It is a combination of one alpha, one beta, and one gamma. So it is called the trimeric, heterotrimeric. Hetero means different. Trimeric means three. So it's a heterodimer or a heterotrimeric protein, which are a combination of alpha segment, beta segment, and gamma segment. So once if it is stimulated, what will happen? This beta and gamma segment will separate from this, and this alpha segment will go and occupy another site from where it will stimulate what is called the adenyl cyclase. This happens by the phosphorylation, by the phosphate ligand going and attaching itself. Whereas in the acetylcholine, what happens once it is stimulated, it is an inhibitory. You can see here it is GA here, and this will block the conductance of potassium as well as the inhibit the action of adenyl cyclase. So the opposite effect will happen. Whereas here the adenyl cyclase is stimulated, so more of cyclic AMP will be released or available, and then phosphokinase A system will be stimulated. So this will cause calcium to enter, to cause more release of calcium, and either a stimulatory effect on the muscle fiber or the gland will be taking place to affect all these things. So this is the main way of signal transduction. What you have to remember is both beta adrenergic and muscarinic receptors are G protein coupled receptors. This question is quite often asked in the theory examination as a short note or a long note, a long question also under the heading of pharmacology, where you have to know about the mode how these intracellular signaling or transduction of impulses happen. So the signal transduction from systems B adrenergic and muscarinic stimulator, these are all the ligands. So this is TSS3 stimulatory protein, acetylcholine, type 2 muscarinic receptors, all the expansion for all these things. And now you find lastly here a word called phospholamban, ELB in the short form, and the expanded form is phospholamban. What is the role of this phospholamban in cardiac muscle contraction? All the other words you would have heard about: the sarcoplasmic reticulum, release of calcium, ryanodine receptor. What is the importance of ryanodine receptor if it is mutated?
More chances of
Malignant hyperthermia.
The basic pathophysiology in malignant hyperthermia is the mutation of this ryanodine receptor. Okay, so this is the ryanodine receptor. This is the sarcoplasmic reticulum. So this acts like a guard. So when calcium comes and stimulates this, this will open and allow calcium inside to come out. And this is what is called the calcium stimulated calcium release. And when the calcium is liberated into the sarcoplasmic reticulum, it will cause contraction. And then it will be separated again and then pushed back into the sarcoplasmic reticulum as a storage. That is done by closure of this ryanodine receptor. But in patients who have a genetic tendency to develop malignant hyperthermia, what happens is this ryanodine receptor, which is stimulated and which opens to release the calcium, it does not close back. It remains open for a longer time. So there is a continuous extrusion of calcium, which goes on stimulating the muscle and keeps it into a contracted state. That is why in malignant hyperthermia, when you induce the patient and you give a relaxant, your jaw is not well relaxed in spite of giving dexamethasone. If you find your patient's jaw is not relaxed and you are not able to introduce your laryngoscope, you have to suspect that this patient may have or may go in for malignant hyperthermia, because the muscle, even under the effect of a muscle relaxant, because dexamethasone, why it causes the muscle contraction instead of relaxation here? What do you normally see when you give dexamethasone to a normal patient without evidence of malignant hyperthermia? Have you been using dexamethasone? Have you seen dexamethasone being used?
Sir.
Because nowadays
Yes,
most
sir.
of the anesthetists prefer to go straight for the non-depolarizer. What is the response you will see to?
Fibrillation followed by complete relaxation.
It is not called fibrillation. What is the correct word to use?
Fasciculation.
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 Why that fasciculation happens?
Because of
Initially, it will depolarize the muscle because it looks the dexamethasone. What is the structural nature of dexamethasone?
made up of two
It
acetyl
is a 2-acetylcholine.
It is nothing but 2-acetylcholine molecules combined with the ester link. Okay, succinylcholine is succinyl dicholine. Nothing but two molecules of acetylcholine combined with a ester bond. So, because it resembles the structure of acetylcholine, initially it will cause a mild stimulation of the motor units. That is why you get that fasciculation. Okay. After that, it will continue to block the sodium channels and not allow the transition of the sodium and potassium exchange, and so the muscle remains paralyzed. So in that patient, that small stimulation is enough to keep the ryanodine receptors open and the calcium being extruded, and that is why the mesenteric spasm, preventing the application or entry of your laryngoscope, introduction of your laryngoscope becomes difficult in these patients. Okay, so you have heard about all these other words about adenyl cyclase, protein kinase A, L-type calcium channel. All these things are familiar words, but what is the role of this particular substance, phospholamban?
It's a regulator of Cerca pump, mediating in calcium channel for contraction.
Excellent, very good. Okay, so it's a key regulator of cardiac contractility and modulates this SR calcium sequestration. So the Cerca activity is controlled by the phospholamban. Okay, very good answer, correct. So sequestration by SRCA2 ATPase in its dephosphorylated state. Okay. So if there is a deficiency of this phospholamban, again you may have a problem just like you have a malignant hypothermia. So upon phosphorylation, which is mediated through beta adrenergic stimulation, the inhibitory effect of phospholamban on the function of Cerca is relieved, and this causes the stimulation. So the main initiator of the release of calcium from Cerca is by inhibition of the phospholamban caused by the beta adrenergic stimulation. Okay, that is a major action of that. What are the types of calcium channels and what is their properties? We have been talking about calcium because it is the main ion which is responsible for sarcomeric contraction. So the calcium is a mainly extracellular ion. So it enters the cells wherever it has its action and then stimulates the release of further calcium from the endoplasmic reticulum, and then goes and attaches itself to the actin myosin complex area or the sarcomere, and then initiates the contraction. So for the calcium to enter the cells, how many types of channels are there?
L-type and T-type of channels.
Channels. Any other?
One for the muscle contraction, one for the impulse generation.
Impulse generation. Only two types, or any other types are there?
N types in the neuronal cells.
Yes, there are totally three types of calcium channels: T type, L type, and N type. You know why they are called T, L, and N? Is it any indicator of their nature of action or any activity? So this picture will give you all the answers. The L type means it's a long-lasting current action. T type is transient current action, and N type is neuronal. So these two are mostly in the cardiac muscle or the other voluntary involuntary muscles, whereas N type is mainly in the nervous tissue, and their speed of conductance differs. L type has a very long conductance period, 25 ps. T type has got 8 ps, and N has 12 to 20 ps. Now the activation threshold is quite high with L type, whereas the activation threshold is low for T type, and this is high for N type. And inactivation rate is very slow in L type fast in P type and medium in N type. Where are they located and function? It is the excitation contraction coupling in cardiac and smooth muscles done by the L type. Again, SA node, AV node conductivity is also by L type calcium channels. Endocrine cells hormone release and neurons transmitter release, all these things are by L type. Whereas T type is present in the SA node pacemaker activity and T current and repetitive spikes in thalamic and other neurons, some endocrine cells and certain arteries for constriction. And the N type is only on neurons in the central nervous system and sympathetic, as well as myenteric plexus in the intestines, and it causes release of transmitter. Now, what are all the drugs which can block the L type? Commonly, we use these drugs. All of us are familiar with this nifedipine group of drugs, diltiazem group of drugs. Diltiazem actually is a single drug, and verapamil. Now, what is the basic chemical name for all these drugs? What does verapamil come under? Which category of drugs? Diltiazem, nifedipine.
Dihydropyridines.
Nifedipine, amlodipine, all cyclidipine, clendipine, all these dipines are dihydropyridine compounds. These two are classified as diltiazem and verapamil. Non-dihydropyridines, or more specifically, is there any name for these two groups, these two drugs specifically? The nifedipine all come under dihydropyridine. Okay, diltiazem and verapamil can classify them together as non-dihydropyridine, but individually, is there any name for the chemical group under which they are classified? They are called phenylalkylamine and benzothiazepines. Okay, diltiazem comes under a group called benzothiazepine, PANE, not diazepam, diazepine. Whereas verapamil comes under phenylalkylamines. Okay, so that is how the individual, but you can call them as non-dihydropyridine also. So they all block only the L-type channels. Whereas the T-type channel is blocked by mebifradil, flunarizine, and ethosuxamide, not commonly used. And of course, for the N-type, you have phonotoxin. So these are the blockers for these various calcium channel blockers. Now in the conductance, you find that there is a name called PS. PS mentioned here. What is PS mentioned against the conductance above? What is the meaning or expansion for the PS?
Seconds.
Picosiemens, not seconds. Okay, symbol for PS is picosiemens, which is an SI unit of electrical conductance equal to 10 to the power of 12 minus 12 Siemens. Okay, conductance is measured in a SI unit called Siemens, and that is 10 to the power of minus 12. So Siemens is the symbol for electrical conductance, electrical suspendance, and electric admittance in international system of units. So that is just a small tidbits. Now name the hormones which can increase the heart rate. Now we saw
Adrenaline.
the ANS. That comes under catecholamines or
Catecholamines.
Catecholamines.
Epinephrine, norepinephrine, dopamine.
They are all catecholamines. Okay, is one. Any other hormone? What happens in thyrotoxicosis?
It's the
Thyroid hormone.
So you can see catecholamine, endothelins, aldosterons, ADH, thyroxine. Okay, all these hormones are capable of increasing the heart rate. Catecholamines, endothelins, aldosterons, ADH, and thyroxine. Okay, what about hormones which decrease the heart rate?
Acetylcholine.
Acetylcholine. Then
TSH.
TSH. Okay. So natriuretic peptide, neurokinin A, oxytocin, and acetylcholine. Okay. These are the 4 hormones which can decrease the heart rate. Natriuretic peptides, neurokinin, oxytocin, and acetylcholine. Okay. So 5 hormones which can stimulate the heart rate, 4 hormones which can decrease the heart rate. Now, what are the drugs and chemicals which can alter heart rate? Now, we saw about hormones, which are endogenous natural ligands, but drugs and chemicals which can alter the heart rate.
Sir, atropine, glycopyrrolate, isoprenoline.
So you can classify them as sympathomimetic and parasympathomimetic drugs, isn't it? That way it is easier, isn't it?
Yes,
So the effects of drugs we have digitalis, atropine, beta blockers, pulmonary bronchodilators, they cause tachycardia, and stimulants like caffeine, nicotine, cocaine, all these also result in tachycardia. So drugs which can cause increase in heart rate can be atropine, it can be isopropanol, can be caffeine, nicotine, and cocaine. And drugs which cause decrease in heart rate, beta blockers mainly. And what environmental factors can affect the heart rate?
temperature, acidosis.
Here,
High altitude.
So blood sugar level, emotional stress, lack of sleep, stress due to any factor, anger, fear, etc. These are all those that demand the increase or decrease. So normally what will happen? They increase the heart rate or decrease the heart rate?
Increase the heart rate, sir.
Most
Increase
of
the
them
heart.
increase the heart rate. Yeah. Okay. So what are the hormones released by the heart? Now we saw the hormones acting on the heart, but heart itself releases some of the hormones. What are the hormones released by the heart?
Natriuretic peptides.
Atrial natriuretic peptide, very good. Then can you say a few words about atrial natriuretic peptide? Which part of the heart it is secreted? What is their action? What causes the release?
Which is secreted by both atrium. Normally, it is secreted by the atrium. During failure, it is also secreted by the ventricles. It levels rises during heart failures.
Heart failure. What about BNP? You said this is about, if you say ANP is responsible for heart failure, what about BNP? Brain natriuretic peptide. Which is the one secreted in heart failure, ANP or BNP?
BNP, sir.
BNP, sir.
BNP. So we will see that. What is ANP? Atrial natriuretic peptide is produced by atrial cardiomyocytes and serves to reduce the blood pressure through several mechanisms. That is the main activity of ANP, is to reduce the increase in the blood pressure if it happens by mechanism. ANP is mainly produced, stored, and released by atrial myocytes, while also being produced in the suprarenal glands and renal glands to some extent. Now, what causes the release of ANP? Which are conditions which will cause the release of ANP? You see, there are 5 major causes of ANP release. One is the abnormal distension or stretching of the atria. If there is a beta adrenergic stimulation, or if the patient has hypernatremia, or increases in angiotensin 2, or increases in endothelium. So all these factors will cause the release of ANP. Now once ANP is released, what are the effects of ANP on vasculature and heart? We have already seen that it reduces the blood pressure. So what should it do to reduce the blood pressure? Will it cause vasoconstriction or vasodilatation?
Vasodilatation followed by fall in the heart rate.
Heart rate. Very good. Upon vasculature, ANP blocks catecholamines. While in the heart, it inhibits hypertrophy by blocking norepinephrine-stimulated protein synthesis. Okay? It also exhibits cardioprotective properties related to its ability to block cardiac fibrosis following ischemia reperfusion injuries also. Okay? Now comes the next part of it. What is BNP and its importance? Now ANP says it is atrial natriuretic peptide, so naturally we can understand that it is secreted by the atria. Whereas BNP, if it is responsible to identify cardiac failure, which part of the heart should secrete that?
Ventricles.
Logical thinking, ventricles. Okay, so brain natriuretic peptide is produced by ventricular cardiomyocytes. Unlike ANP, which is produced by atrial myocytes, this is produced by ventricular cardiomyocytes, but works in a similar fashion to ANP. BNP is secreted by the ventricles of the heart in response to excessive stretching of ventricular myocytes, just like atria getting distended, stimulating ANP production. When the ventricles get excessively stretched, ventricle produces BNP, and its level typically increases in patients with left ventricular dysfunction. So elevated levels of BNP, the normal level is 125. What is PG?
Picogram.
Picogram
per ml in young patients and 450 picogram per ml in old patients are thought to be indicative of poor left ventricular function and heart failure. Okay, so estimation of BNP has become a routine investigation nowadays to identify the severity of heart failure in patients with cardiac problems. Okay, especially those with cardiomyopathy or dilated cardiomyopathy secondary to long-standing hypertension. Okay, in all these patients who suffer from cardiac failure, especially left ventricular failure, if you find the BNP value is very high, you can estimate the severity along with the ejection fraction. You can take them into account to assess the severity of the left ventricular failure. Okay. What substances are produced by endothelial cells? What are the effects of thyroxine on heart? So first we saw the hormones extraneously from acting on the cardiac function. Then we saw the hormones secreted by the cardiac muscles, namely the atrial myocytes and ventricular myocytes. Now we want to know what are all the structures or substances produced by the endothelial cells and what effects thyroxine causes on the heart. What is the most important chemical produced by the endothelial cells to cause vasoconstriction or vasodilatation?
Adenosine. Intimidators.
Endothelin. Okay, endothelin 1 is a potent vasoconstrictor that is produced by endothelial cells. So there are 4 types of endothelin receptors which are mainly expressed in the vascular smooth muscles, and their subtypes are endothelin A, B1, B2, and C. Okay, and they are also G protein coupled receptors, and their ultimate action results in elevation of intracellular free calcium so that the smooth muscles can be contracted. The actin myosin complex can be stimulated to produce vasoconstriction. Okay, and this is active. If you activate endothelin A, it results in smooth muscle vasoconstriction. Endothelin B causes release of nitric oxide from the endothelial cells, and a part of that itself causes vasodilatation. So the nitric oxide, which is earlier, what is the name for nitric oxide?
Endothelin.
EDRF. I will tell you the short form. Earlier name for nitric oxide was EDRF. Can you tell me the expansion?
Endothelin releasing factor.
EDRF.
Derived relaxing
Derived
factor.
releasing factor. Fantastic. It is endothelium derived relieving factor was the earlier name for nitric oxide. And once they found that it is the chemical structure, they were able to identify it is a nitric oxide. So the name EDRF was removed and it is been now constantly used as nitric oxide. So the component or isoform of the endothelin receptor B is responsible for causing vasodilatation also. What is the effect of thyroxine? It's a hormone produced by the follicular cells of the thyroid gland. While it acts on nearly every cell type within the human body, its most important function is to increase the effect of epinephrine. So thyroxine does not directly cause its action. It indirectly causes or enhances the effect of epinephrine, which is a catecholamine. So that is the mechanism of thyroxine. Through this permissive relationship, thyroxine increases the number of beta-1 receptors and thus indirectly responsible for increasing the cardiac output, resulting in both inotropic and chronotropic manner. Clinical increases in thyroxine are associated with occurrence of atrial fibrillation, which is a common cardiac arrhythmia in patients with thyrotoxicosis. Elevated heart rates from thyroxine-induced atrial fibrillation or other arrhythmias can result in myocardial decompensation and heart failure if not returned to normal sinus rhythm as early as possible. IV thyroxine, we use it during organ retrieval from brain dead donor patients. Okay, so because the production of thyroxine will be inhibited in patients with brain dead. So before retrieving the organs, we invariably supplement IV thyroxine to preserve the functional status of the organs that are received. Now, having seen the conduction system, I mean the control of the cardiac activity through the ANS and the hormonal and other system, we must know something about the pharmacology of drugs acting on the cardiovascular system also. So the first group will be what are the drugs that are used in the treatment of acute and chronic heart failure, because they all have implications to our anesthetic drugs. Interactions are there. So we must know something about the drugs acting to treat acute and chronic heart failure. Can you just mention at least a few drugs?
Diuretics.
To increase the chronotrophy and diuretics to decrease the low.
So these are the drugs which are nowadays used. The first preference is AC inhibitors, then angiotensin 2 receptor blockers, beta blockers, mineralocorticoid receptor antagonist, that is aldosterone antagonist, diuretics, ivabradine, sacubitril valsartan, armi, hydralazine with nitrate, and digoxin. Okay, so these are all the group of drugs. Any of them or a combination of them are used nowadays to treat acute or chronic heart failure. Now, in this list, you may be aware of the few drugs, but I don't know how many of you are aware of these two drugs which are given as after diuretics and before hydralazine, this ivabradine and sacubitril valsartan. So I thought I will give a little bit of, because these drugs are being prescribed by cardiologists nowadays very frequently. So I thought we should be aware of those drugs. Can anyone say What group it belongs to? The ivabradine?
It's a funny sodium channel.
Funny channel inhibitors.
Funny channel blocker. That is, what about
Sodium.
nitrocontin, which was given earlier for my skin patients? It was a drug prescribed called nitrocontin. Have you heard of that? Nowadays, of course, many cardiologists don't prescribe that. Anyway, this correct answer for this is ivabradine is a class of medication which blocks the hyperpolarized activated cyclic nucleotide gated channels, HCN channels for short form. Okay? So this is what is happening. This is SA node. SA nodes stimulated by the atrial natriuretic factor and 5-hydroxytryptamine is inhibited by antidiuretic as well as acetylcholine, and noradrenaline also stimulates. These are the common hormones that we saw earlier. Now, when there is a normal stimulation, the HCN channel, there is a lack of function, and there is a gain of function and there is a stimulation, post-transitional modification of HCN2 and HCA4 atrial fibrillation. So nowadays they have identified this HCN channel, even though it is a part of the sodium channel, to permit the sodium entry. They have identified this ivabradine chemical which is able to act on that. So in what way beta blockers also decrease the heart rate and decrease the oxygen requirement of the, that is the reason why we give that mainly for patients with cardiac failure and ischemia. Beta blockers are given to reduce the heart rate and reduce the workload and also decrease the oxygen requirement. Now, in what way this ivabradine differs from the beta blocker?
Ivabradine
Beta
does not
blocker, of course,
interfere
it
with
blocks
the
the beta 1, beta 2 receptors, isn't it? Whereas this ivabradine, in contrast to beta blocker, it reduces the heart rate both at rest as well as during exercise, with minimal effects on myocardial contractility, blood pressure, and intracardiac conduction. The reduction in heart rate and increased diastolic filling time also gives a beneficial effect on the myocardial relaxation. So it improves the diastolic dysfunction. That is the reason why this drug is given. Whereas if you give beta blocker, it will simply reduce the heart rate and decrease the oxygen requirement by reducing the contractility. That is all it does. Whereas ivabradine is a little superior in that it causes a relaxation. The lusitropic effect on the myocardium is more, which causes a good diastolic filling so that the next ejection fraction or the contractility stroke volume will improve. So that is the main reason why this drug is now given over. This is preferred more over the beta blockers for treating chronic failure, especially chronic heart failure patients with low ejection fraction. This drug is being given in doses of 5 to 10 milligram per day, once or twice. That is the dosage also. So you can just remember this particular drug. Now another drug I showed you is sacubitril valsartan, and in the bracket it is written as ARNI, RB. What question is, what is sacubitril valsartan? What is the expansion of RB?
It is angiotensin and angiotensin receptor and neprilysin inhibitor combo,
Inhibitor.
ideally used for heart failure.
Excellent, very good. So valsartan, is it sacubitril valsartan? Is it a single drug or is it a combination?
It's a combination of two classes of drugs.
Two classes of drugs. Very good. So what does sacubitril do? What does valsartan do? What is valsartan?
Angiotensin receptor inhibitor.
Receptor blocker. So it is a combination of angiotensin receptor blocker plus this neprilysin inhibitor. So that is why it is called the ARNI. Okay, this valsartan is the AR component, angiotensin receptor component. This sacubitril is the NI component. Okay, so here in the name the sacubitril comes first, valsartan comes next, but they have reversed it for remembering as an acronym. ARNI is more easier to using NIR. NIAR means it will be NIR. Okay, that may look like Nair, they confuse you. So it is, instead of that, they have kept it as ARNI, which is easy to remember. So sacubitril valsartan is the first agent to be approved in a new class of drugs called angiotensin receptor neprilysin inhibitor. That is the expansion for the acronym ARNI. The medication is FDA approved to treat patients with chronic heart failure with reduced ejection fraction. Nowadays, patients, if you see the cardiologist reports on echo, they will say earlier it was only EF, so much percentage will be given. But if the patient now has heart failure, known case of CCF, they write HF with REF or HF with PEF. So heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. That is how the patients with chronic heart failure are classified nowadays. So whenever the ejection fraction is reduced, the drug they prefer to give is this sacubitril valsartan. It is a combination product. It is a pro-drug. This first part of the drug, sacubitril, is a pro-drug that upon activation acts as this neprilysin, which is a membrane peptide. So it acts on that and inhibits that. By blocking the action of neprilysin, it prevents the breakdown of natriuretic peptides. That is the atrial natriuretic peptide and the brain natriuretic peptides. These are the drugs which earlier we saw how they help in the cardiac function by reducing the blood pressure and improving the contractility, all those things. So those natriuretic peptides are, and life is prolonged. Can you think of some similarly acting drugs in the gastrointestinal system? You talk about preventing the breakdown of ANP and BNP in the heart to enhance their action duration. Can you think of a similar mechanism where we use drugs in diabetic patients to enhance some activity in the gastrointestinal tract?
Amatostatin, I don't know.
So, diabetic patients.
Carbos.
GLP-2.
GLP-2, you don't use them directly. Dipeptidyl peptidase inhibitor. We use them, isn't it? So dipeptidyl peptidase inhibitors increase the duration of the incretins, isn't it? So they are able to break down the glucose that is absorbed. So similar to that, here it prevents the breakdown of natriuretic peptides. So that is the role of sacubitril. Then the second half of the drug, valsartan, is an angiotensin receptor blocker, and it works blocking the RAAS system. What is the expansion for RAAS system?
Renin angiotensin
aldosterone system. Very good. So that is the main reason for your cardiac function. So it works on blocking the RAAS system now. And because neprilysin breaks down angiotensin 2, inhibiting neprilysin will accumulate angiotensin 2. So that is the reason why this sacubitril cannot be given as a single drug, even though its main action is to prevent the breakdown of natriuretic peptides, ANP and BNP, and help the myocardium. It cannot be given alone because it will not also allow the breakdown of angiotensin 2. What is the effect of angiotensin 2 on the vasculature?
It increases the blood pressure.
Vasoconstriction and raises the blood pressure.
Blood pressure will increase. So you cannot give this drug. So to block that angiotensin action, you have to give necessarily add the angiotensin receptor blocker also with this. So for this reason, a neprilysin inhibitor cannot be used alone. It must always be combined with ARB to block the effect of excess angiotensin 2, which is also a side effect of neprilysin. Okay. So these are the two main functions of neprilysin: preventing the breakdown of natriuretic peptides and also preventing the breakdown of angiotensin 2. So in order to counteract this accumulation of angiotensin 2, neprilysin inhibitor should always be combined with angiotensin receptor blocker drugs. Another substance which is broken down by neprilysin is bradykinin. So third drug. So here it prevents the breakdown of natriuretic and the neprilysin, whereas it breaks down the bradykinin. So when you inhibit that, what will happen? It will allow the building up of bradykinin also. So therefore, it cannot be used in combination with angiotensin converting enzyme inhibitors, which will cause an increased risk of angioedema. Okay, that is the reason why ARBs are combined with sacubitril and ACE is not used. But when switching between ACE and sacubitril, if you want to shift from this combination to this, patient must wait at least for 36 hours. It is 1.5 days you have to wait for the washout period to lower the risk of angioedema. Okay, so these are all a few points about this. And the very, very important is this drug is be given only if the renal function is normal in a congestive cardiac failure patient. So if the renal function is normal and patient suffers from reduced ejection fraction congestive failure, this drug is supposed to help them very well, and those patients improve their cardiac output, stroke volume, and their day-to-day activity and effort tolerance definitely increases. I have seen 1 or 2 old patients in my friends' family and relatives where cardiologists have preserved this, and they have remarkably improved. Patients who cannot even get down the bed and go to their washroom for their natural calls, they improved very well within 1 week of treatment with this drug. But the main important precaution you have to observe is they should have a normal urea and creatinine to indicate that their renal function is normal. Usually patients with long-standing congestive failure also go in for compromised renal function because the renal perfusion is also decreased. They always have a borderline or a minimal renal dysfunction. So if you give that drug in these patients, then the ARB worsens the renal condition and they go for renal failure because ARB is a double-edged weapon. In the early stages of renal failure, it will help. But in patients with advanced renal failure, it will worsen the condition faster. So only caveat that you have to look into is the renal function before prescribing this drug, especially patients, the diabetic congestive cardiomyopathy type patients, they do very well if the renal function is normal. Now, what is the drug therapy for systemic hypertension? This is another common thing which we all of us know because we come across or encounter nowadays patients with varying drugs for hypertension. Even young patients working in the IT sector, they all develop hypertension by the age of 30, 35 and come with varying combinations or degrees of hypertension. So we should have some idea about the antihypertensive drugs. So what are the drugs that are commonly used to treat hypertension, or how do you classify the drugs or antihypertensive drugs? This is one of the theory questions also asked in the basic science first or second paper. So I thought we can have some discussion on that. So how can you classify antihypertensive agents?
AC inhibitors and
AC
ARB
inhibitor,
inhibitors,
ARBs,
beta blockers,
AC
calcium
inhibitor,
channel
ARB is
blockers,
very good.
beta
diuretic,
blockers,
Beta
calcium
blocker,
channel blockers,
calcium channel blockers,
diuretics,
Diuretics.
alpha
diuretics,
2
alpha 2 agonists. Very good. Right. So this list starts with the diuretics. So the thiazide diuretics, out of which you have so many drugs: chlorothiazide, chlorthalidone, hydrochlorothiazide, polythiazide, indapamide, and metazolone, loop diuretics, bumetanide, furosemide, torsemide. So these are all the thiazide group of drugs. Loop diuretics are the three: bumetanide, furosemide, and torsemide. Potassium sparing diuretics, amiloride and triamterene. The aldosterone receptor blockers, eplerenone, spironolactone. Aldactone, all of you must be very quite aware of. This eplerenone is not a very commonly given drug, but patients who, some people are prescribing this also. Aldactone, what is the condition apart from hypertension commonly used? Where do we use this spironolactone or aldactone in a condition other than cardiac hypertensive disorders? Patients in NEOT doing a lot of liver transplantations.
renal transplant,
PCLD patients to prevent hypothermia.
Cirrhosis liver patients, invariably they'll be put on this, okay, spironolactone. And then comes the beta blockers, atenolol, bisoprolol, metoprolol. So beta blockers, how do you classify the beta blockers?
Cardioselective and non-cardio.
Excellent. Non-selective or more specific or cardioselective. So this atenolol, bisoprolol, metoprolol, all these things are all cardioselective. They act on the beta 1 receptor alone. Whereas the original propranolol, the first beta blocker to be introduced, it is a non-selective beta blocker. So it will act both on the beta 1 and beta 2 receptors and block both the activities. So that will be causing more chances of bronchospasm in patients who have asthma or COPD. So this is a very important point we have to know. So what are the other indications for propranolol apart from this as an antihypertensive? What other conditions propranolol or Inderal is being prescribed? Non-cardiac anxiety disorders. Very good.
Thyrotoxicosis.
Thyrotoxicosis. Very good. Have you ever been?
patients.
Migraine. It is one of the drugs which is
Migraine.
commonly prescribed in patients with migraine. Okay. So thyrotoxicosis, anxiety disorders, migraine, and non-intentional tremors other than Parkinsonism. Okay. Patients who have tremors, they also do well with propranolol if it is not of Parkinson's origin. Okay. So these are the other non-cardiac indications of the non-selective beta blocker propranolol. And we have beta blockers with sympathetic activity, intensive sympathetic activity, which are acebutolol and tenbuterol and pindolol. And there are combined alpha and beta blockers, this carvedilol and labetalol. Labetalol, all of you are very familiar, being used in which condition? Both
Pregnancy-induced hypertension.
Pregnancy-induced hypertension. Very good. So this is the drug of choice for pregnancy-induced hypertension control. Then we use angiotensin converting enzyme inhibitors, but they are slowly going out of fashion or out of use. Why? When they came into market, they were the drugs preferred And in fact, the Joint Commission on Treatment of Hypertension recommendation was originally beta blocker for control, first drug of choice, or first line of drug was beta blocker. That was changed to AC inhibitors when it was marketed. But now, which is the drug of choice for first line of choice for treatment of hypertension, especially in younger patients?
ARBs.
ARBs, very good. ARB is the first drug choice for all cases, especially young hypertensive. And the reason why AC is going out of fashion or out of use is, one is it has got the risk of producing a angioedema. Angioedema because of why angioedema can happen. Is it allergy or histamine release or related to something else?
Bradykinin, sir.
Bradykinin.
Accumulation of bradykinin produces that edema. So it is not called angioneurotic edema. It is called just simply angioedema. Whereas histamine release or allergic edema, anaphylactic edema is called angioneurotic edema. Okay, whereas the edema caused by AC inhibitors we called only as angioedema. Okay, then other reason is it also produces severe cough because of the accumulation of bradykinin. It also causes cough. So that is the reason why these drugs are not prescribed nowadays commonly, and preferred drug nowadays is angiotensin 2 receptor antagonist or angiotensin receptor antagonist, which are candanceton. All of these drugs end with sartan. They are called sartans, and olmesartan, telmisartan, valsartan, all these drugs are there in various dosages. Then the next preferred is calcium channel blockers, non-dihydropyridines, out of which diltiazem, verapamil. These are the two common drugs which are available. Under dihydropyridines, you have the oldest, the nifedipine is the oldest drug which was introduced first. Then came amlodipine, then felodipine, isapridine, and all these other recent class of drugs. And then alpha blockers, that is daxothozine, prazosin, and tazosine, are also used in some patients. Apart from as an antihypertensive, what is the use of these alpha 1 blockers?
Inhibit smooth muscle hypertrophy.
BPH.
Treatment of benign hypertrophy of the prostate. Okay, it is one of the drugs preferred for treatment of medical management of BHP. Okay, and of course the centrally acting alpha 2 agonist, clonidine patch, metholdopine, reserpine. Of course, methyl-dopa now has become more obsolete now, and direct vasodilators like hydrolysine and minoxidil. So this entire list gives you the drugs that are used in hypertension, and patients may be taking any of them and coming for surgery and anesthesia. So we should have some idea about the implications to anesthesia in these these drugs are being used in the patients, which we will see subsequently now. So starting with diuretics, go to beta blockers with sympathetic activity, AC inhibitors, ARBs, calcium channel blockers, alpha blockers, and alpha 2 agonists and direct vasodilators. This may be the classification of all the antihypertensive drugs. Now to identify the drugs, I thought this slide will help you. AC inhibitors, their name ends with the word pril. So lisinopril, enalapril, all these things were classified as AC inhibitors, and their action is to block the effect of AC, active angiotensin converting enzyme, which produces a drop in SPR and so forth. ARBs, they will end with sartan, sartan, valsartan, and they block the AR angiotensin receptors, and their action is also similar. Alpha blockers end with osin. doxazosine, terrazosine, prazosine, so they end with ozine. And beta blockers, they end with lol, not laughing out your life as you put in your WhatsApp language, but this is metoprolol, labetalol, and the block beta receptors. They decrease heart rate also compared to the other drugs. If you want reduction in heart rate, you must use beta blocker also. And calcium channel blockers, they mainly end with dipine, amlodipine, nicardipine, and they decrease SVR. Diuretics, mostly they end with ide, furosemide, hydrochlorothiazide, and they facilitate diuresis and cause decrease in stroke volume. Now, what are the drugs used in the treatment of cardiac arrhythmias? So, this is another important thing which we all should know. What type of arrhythmia, what drug to be given, what is the what are the, how do you classify the cardiac arrhythmias?
4 classes of antiarrhythmics: sodium channel blocker,
That is
beta
drug
blocker,
classification. Now the question
Supraventricular
is how,
tachycardia.
supraventricular,
Supraventricular and ventricular tachycardia.
tachycardia is one classification. Another classification is tachyarrhythmias and bradyarrhythmias, isn't it? Long
Yes, sir.
QT, short QT interval arrhythmias. So there are so many other classifications. So we must know what drug to be used in what type of arrhythmia. That is very, very important. So to describe that, this picture I thought will be very easy. If you, we saw about the action potential in the last class about the myocyte, because it is the myocyte which goes into arrhythmia, not the pacemaker cells. So pacemaker cells are responsible only for generating, as I told in the last class, the electrical energy. They don't actually contract. Whereas the muscles which contract only have to go in for arrhythmia. So the cardiac myocyte, you have the phase 0, where sodium influx causes the depolarization. That's what we saw in the last class. So if this is the responsible mechanism, then you have to go for any of the sodium channel blockers. The class 1A is increase in action potential duration. So if that is the reason, then you use quinidine or propanamide. If the action potential duration is lower, go for lidocaine mexiletine. The strong, go for plecanide or propofane. Now the then as we saw, after depolarization, there is an efflux of potassium which brings down the partial repolarization act. Immediately calcium enters and maintains the depolarization at a plateau, and after that, when the calcium channels also close, the repolarization starts and the phase 3 occurs. So we have, if we understood all these things, then we can easily select which drug to be used. So diltiazem and verapamil, they reduce the influx of calcium. So which conditions do you think you should use this? Diltiazem and verapamil are indicated in which particular type of arrhythmia? Supraventricular tachycardia. Okay,
Yes.
SVT. So for SVT, this is the drug of choice. Okay, whereas for atrial fibrillation, this is the drug of choice. Okay, class 3 potassium channel blockers and sotalol. And one drug, if you remember, which can be used in both atrial fibrillation and ventricular fibrillation is this drug. So if you give amiodarone, you can manage, even if you are wrong, you can safely manage both atrial and ventricular fibrillations. Whereas you cannot use diltiazem or verapamil for ventricular fibrillation. Okay, and metoprolol or atenolol are beta blockers which are used in simple sinus tachycardia. Okay, so that is how the drugs are chosen. Now, what is the effect of volatile anesthetic agents and cardiac function? How do volatile anesthetic agents affect the cardiac function?
Cardiac
there any
depression.
Direct
Cardiac depression.
depression. By what mechanism? Of course, they do cause cardiac depression, correct. Answer is correct. But what is the mechanism? How do they? Depression means they should reduce the contractility of the cardiac muscle, correct, isn't it? When you say volatile anesthetics depress the cardiac muscle function, that means they depress the contractile force of the cardiac musculature, correct? So what is responsible for the cardiac contraction?
They alter the potassium and calcium channels.
Potassium and calcium channels, but what is the main ion we saw is responsible for the actin myosin complex to go in for contraction?
Calcium.
Calcium, isn't it?
Calcium
Is important.
Yes, sir.
And for calcium to accumulate to cause the contraction, what is the messenger which is important? Cyclic AMP. Okay, so all volatile anesthetics have shown to induce a dose-dependent decrease in, instead of saying myocardial depression, remember myocardial contractility. That way you will know what will be the mechanism of action. And cardiac loading condition. These depressant effects decrease myocardial oxygen demand and may therefore have a beneficial role on the myocardial oxygen balance during myocardial ischemia. That is why in cardiac anesthesia, they describe the anesthetic technique as either a volatile based anesthesia or opioid based anesthesia. So if any of you want to become a cardiac anesthetist in future, you have to know that preservation of myocardial function, especially in ischemic heart disease patients coming for cardiac surgery, you can use what is called a volatile based anesthetic technique or a opioid based anesthetic technique. Okay? For that, you have to remember this point. Now, are there any interactions between calcium channel blockers and anesthetic agents? If your patient comes with some, say, amlodipine, nifedipine, or felodipine, quinidipine, any of the hydropyridine group of drugs. Now, what is the mechanism of action of calcium channel blockers? Which channel they block? The L type, T type, or N type? That is the reason why I put that calcium type calcium channels type slide earlier for you to understand and answer all these questions. L type.
channels.
Okay. Yeah, inhalation agents decrease the availability of intracellular calcium, which in turn enhances the negative inotropic, chronotropic, and chromotropic effects of calcium channel blockers. So if you use inhalation agents in patients who are already on treatment with calcium channel blockers, inhalation agents themselves decrease the contractility. So in addition to that, if the patient is also on calcium channel blockers, there is a chance that their cardiac function in the form of inotropy, chronotropy, and chromotropy all can be inhibited. They can potentiate all neuromuscular blocking agents, potentially impair hypoxic pulmonary vasoconstriction, and they can also mildly increase intracranial pressure. Okay, so for neurosurgical patients, calcium channel blockers are not the ideal drugs for treatment of. If you know a patient has a space occupying lesion and requires a craniotomy for excision of a tumor, it is better that he is put on other antihypertensives if he is hypertensive instead of calcium channel blockers. Okay. Can calcium channel blockers be used during treatment of malignant hyperthermia? Because I told you earlier, it is the mutation of ryanodine receptor which results in failure of closure of the sarcoplasmic reticulum to release the calcium. So there's a continuous leak of calcium into the cytoplasm, resulting in consistent contraction of the musculature, producing intense heat, which clinically exhibits as malignant hyperthermia. So logically thinking, if you give calcium channel blocker and if it blocks the L-type calcium channel, the entry of extracellular calcium into the intracellular compartment will be decreased. So the stimulation of release of calcium from sarcoplasmic reticulum also can be blocked. So in that way, calcium channel blocker can it be a treatment for malignant hyperthermia?
No, sir.
No. Hey.
It is a stored calcium.
Ourselves are causing the crisis.
Very good. You are attempting well. Very good. Continue. So where exactly is the pathology in malignant hyperthermia? Which muscles? Is the skeletal muscle or cardiac muscle? Skeletal muscle.
Skeletal muscles.
So if you give calcium channel blocker, it will also affect the cardiac muscle. So what happens? Cardiac muscle channels are contraindicated during malignant hyperthermia crisis due to increased potential for cardiac collapse after concomitant administration of both calcium channel blocker and dantrolene. Okay, so that is the reason why you should not use calcium channel blockers in the treatment of malignant heart. Now, how many of you heard of this drug? What is phentolamine and what is its use? What are its use?
Pheochromocytoma, we use phentolamine.
First of all, under what category of drug it comes? Phentolamine.
Alpha block.
Alpha blocker, very good. So it comes as an alpha blocker. So if you alpha 1 blocker, if it blocks, what will be the effect?
Hypertensive.
Hypertension will happen or hypotension?
No, sir. Hypotension.
Hypo.
Hypotension can
It is
happen.
a vasodilator. Simply, it is a vasodilator because it blocks the alpha 1 receptor. It is a vasodilator. Okay. So where all will you use it if you want vasodilatation and hypotension? What are all the conditions in which you will use it? You said somebody mentioned about pheochromocytoma. Okay.
Yes,
It's a hypertensive crisis.
Pheochromocytoma, what happens? There is a excess release of catecholamines in the body. So there is a instant vasoconstriction. So BP is always high. So you have to block the vasoconstriction. So you can use phentolamine. But what is the drug which we commonly use for correcting this alpha blocker effect? I mean alpha constriction effect. What is the drug we use in the preparation of a patient with pheochromocytoma? Phenoxybenzamine. Have you heard of that?
Yes.
Phenoxybenzamine, 10 milligram, 2-4
Yes,
times a day. We use to block the effect of this catecholamine and the vasculature producing vasoconstriction. So we first start the patient on phenoxybenzamine or phentolamine, and then once the BP start decreasing, what will happen? Patient will develop reflex tachycardia. To block that reflex tachycardia, we have to add a beta blocker. So the main important role in the preparation of a patient with pheochromocytoma for surgery is to reduce the alpha constriction, alpha effect on the vasculature by alpha blocker, follow it up with beta blocker, and then control the BP and then take up the patient for surgery. You should never make the mistake of first giving beta blocker and then going for alpha blocker. But again, there is one condition which is accepted where you can start beta blocker. Which is that condition? In a pheochromo patient, normal dictum is to start the patient on an alpha blocker for 1 or 2 days or maximum 3 days, then introduce a beta blocker. But in one particular type of achromocytoma, we can start the patient on a beta blocker, then later on add alpha blocker also. Okay, keep this as your homework question and answer this question next week. Okay. Now,
Yes, sir.
phentolamine, is there any way we can reverse the effect of a local anesthetic agent? Supposing you are giving local anesthesia for a dental extraction, and patient says, I want to go and eat immediately, I don't want to wait for a long time. Is there a way the dentist can reverse the effect of local anesthetic?
No.
No. Categorical no. எப்போ இப்படி ஒரு கேள்வி கேட்குறாங்களோ அப்போ அதுக்கு ஒரு எஸ் ஆன்சர் இருக்கணும்னு. It's a possibility you have to think of, isn't it? When a question is asked whether you can reverse the effect, can reverse that. In dentistry, especially Western countries, they were using a drug called articaine, Articaine, which is a amide local anesthetic, which is not available in India. And they found that the duration of action is very, very long for this drug. And patients found it difficult to eat because loss of sensation in the oral cavity. There's a chance of aspiration and inadequate chewing and all that. So they wanted to reverse the effect of that before the patient goes out. They have to, they can be given some oral analgesic, but the numbness can be reversed. So for that, what they did was they injected this phentolamine at the end of the procedure. What will phentolamine do? We have seen now it is an alpha blocker. So when alpha blocking effect comes on, what will happen to the vessels?
Vasodilation.
They dilate. So more blood will come there. So more blood, what will it do?
Wash out the drug and
Exactly.
drug
It will remove the local anesthetic from the nerve endings and regain the or reinstitute the nerve transmission. Okay, that is the mechanism by which this is called the reversal of local anesthetic effect. So read this. Phentolamine mesylate is an alpha adrenergic receptor antagonist used in dentistry for reversal, or more accurately, limiting the duration of action of soft tissue anesthesia after non-surgical dental procedures by promoting local vasodilatation and thereby accelerating the rate of systemic uptake of local anesthetic away from the site of action. Okay. So this is a very common technique that nowadays they use in dentistry for reversing the effect of the drug called articaine. Okay. And phentolamine is also used to manage hypertensive crisis associated with pheochromocytoma, commonly in combination with beta blocking agent to attenuate the increase in the heart rate caused by vasodilatation. Okay. Now, which alpha blocker is used in the medical management of BHP, and should they be discontinued before surgery or continue during surgery?
We use
Prazosin.
prazosin for the medical
Prazosin,
management.
daxosin, more commonly
Prazosin.
tamsulosin. Okay, it's an
Tamsulosin.
drug called tamsulosin. So alpha blocking drug tamsulosin is used for the management of PHP, which has highly selective action. And if prescribed, this medication should be continued preoperatively. So even though it is an alpha blocking effect, it does not cause systemic profound vasodilatation to cause a hypotension. So patients who are already taking tamsulosin preoperatively, they come for TURP surgery, you can ask them to continue the medication. But if they come for a definitive surgical treatment, there is no harm in stopping this drug. If they come for some other treatment, surgery, then tamsulosin can be continued. Okay? For say some elderly person falling down and having a fracture, he comes for a hip replacement or a fracture fixation. Then when you want to take the patient for spinal or GA, tamsulosin can be, it's not a contraindication. Should beta blockers be continued before surgery and anesthesia? or
Yes,
can
sir.
they be stopped?
Yes, sir.
Should be
Yes.
continued, otherwise we could have a
Yes.
refractory
Ah,
rebound hypertension.
very good. An important consideration regarding beta blocker with the strong evidence recommending the patient to continue their usual home dose prior to anesthesia and surgery. So what will happen if they stopped abruptly? You said it is they will have profound
Rebound hypertension.
hypertension. Will they have rebound hypertension? If that is the reason,
Rebound tachycardia, sir.
tachycardia.
Tachycardia.
What will that lead to? Why they develop a tachycardia? If they abruptly stop the, what is the mechanism to cause this problem?
The receptors will become more sensitive.
What do you call that? Very good answer. Correct. But there is a specific term that you have to use. What do you call that increasing number of receptors? It's called
5-axis.
upregulation. It's called
Okay.
upregulation. Okay. So abrupt discontinuation of beta blockers is associated with significant rebound hypertension and tachycardia, which may lead to myocardial ischemia or infarction. Okay. And what causes the effects are these withdrawals are due to increased sympathetic activity, which is probably a reflection of adrenergic receptor upregulation during the period of sympathetic blockade. Okay, so this is the main answer. This is the correct terminology that you should use. Adrenergic receptor upregulation during the blockade. So there are more number of body wants to cause the effect of normal catecholamines on the heart. So when you try to block it with a beta blocker, nature starts producing more beta receptors in the heart. And when you suddenly withdraw the beta blocker, our endogenous catecholamines will go and occupy all these extra beta receptors and cause an increased heart rate and contractility. So the beta receptor upregulation results in hypersensitivity to circulating catecholamines and hence leads to the negative effects that include rebound hypertension, tachycardia on medication discontinuation. Okay. Can beta blockers be used in asthmatic patients?
No,
No,
sir.
sir.
No, no. Very good. You have to be careful, okay? Especially if it is a non-selective beta blocker, should be used with caution in patients with clinically significant COPD and asthma. Okay, that is like propranolol, Indrall. That should not be, as far as possible, avoided in these patients. Selective beta 1 blockers like your atenolol, metoprolol, timolol, which are all beta 1 selective drugs. So they are considered safe. Still, some of the patients may have beta 2 adrenergic blocking effect also, but it is quite significantly less compared to non-selective beta blockers. And when you put a patient on beta blockers, beta 2 agonists like salbutamol is the drug of choice for treatment of asthma, and the effect of this drug will be very much diminished if the patient is on beta blocker. So you have to prefer some other bronchodilator when the patient is on beta blocker, which is especially non-selective. For example, a thyrotoxicosis patient who has been taking Indrall 40 milligram BD or 80 milligram BD for severe anxiety and tremors, and they develop bronchospasm. In that patient, salbutamol may not be of much help. So you have to go for phosphodiesterase inhibitors like deriphyllin or aminophylline rather than depending on the salbutamol, which is the first line of drug for relief of bronchospasm. Okay. What are the adverse effects of beta blockers?
Mask the symptoms of
Bradycardia.
hypoglycemia.
Very good. Ask the symptoms of hypoglycemia in diabetic patients. Okay.
Bradycardia.
Ah.
Sleep disturbances at night.
Including bradycardia, orthostatic hypotension, atrioventricular conduction delays, and hypotension. Okay, so these are the direct cardiac effects: bradycardia, orthostatic hypotension, atrioventricular conduction delays, and hypotension. Bronchospasm, especially if you use non-selective beta blockers. Then, because compensatory glycogenolysis is blunted by beta blocker, warning symptoms of hypoglycemia like tachycardia and tremor are masked. And this is a relative contraindication with patients who have uncontrolled diabetes mellitus, where the blood sugars are very labile. Those patients, we have to be very careful. And beta blockade during pre-operative period can also blunt the effects to surgical stimulation. So if the patient is on a heavy dose of beta blocker, they may not respond to the nociceptive stimulus that is elicited during the skin incision. So that may be in one way advantageous because you may use less opioids. On the contrary, the negative effect sometimes leads to subanalgesic or subanesthetic doses of pain medication, and recovery will be very violent. So it is a double-edged weapon. Patients who are on beta blocker may have a low heart rate. So always see whether the patient can increase the heart rate to a mild stress in the pre-operative period. Whenever a patient is on a heavy dose of beta blocker, ask them to do an exercise and see whether there is at least an increase of 3 or 4 beats from the resting level. If that is there, then the patient will respond to the nociceptive stimulus intraoperatively also. If that does not happen, make sure that you give adequate analgesia on the body weight basis, not depend on the classical features of tachycardia and hypertension to pain stimulus intraoperatively. That will not work out. So you have to be very cautious about this point on patients who are on heavy doses of beta blocker. What will happen if alpha 2 agonist drugs are withdrawn abruptly? What are the alpha 2 agonists which we nowadays use routinely?
Clonidine.
Clonidine,
Dexmedetomidine.
Dexmedetomidine.
These are the two drugs which are very widely used nowadays. And what will happen if you withdraw them abruptly, like beta blockers?
Tachycardia, hypertension.
So they will also have typically rebound hypertensive crisis. What are the benefits of using alpha 2 agonists? Why do we use it so commonly nowadays?
Hypotensive anesthesia.
Do we give it for every case nowadays? We are using. Do we use it for hypotensive anesthesia? What are the effects on
analgesic effect?
analgesic, sedation, okay, and minimal respiratory depression. Okay, benefits of alpha 2 agonists are sedative agent. They also have analgesia, and they are very useful in awake fiber optic intubation. And it also minimizes the need for opioids in obese patients. In fact, one of the technique for bariatric surgery in super morbid obese patient is continuous infusion of dexmed, that is dexmedetomidine, and ketamine. Ketamine for analgesia, dexmed for sedation and analgesia. So combination intravenous maintenance and a relaxant for the surgery is the technique of choice for morbid or super morbid obese patients. And they are also effective in alleviating preoperative anxiety as well as emergence delirium in pediatric anesthesia. Very useful. Now, what are the anesthetic implications of diuretic therapy? If a hypertensive patient is on diuretics along with the regular antihypertensives, what are the anesthetic implications?
We should stop the diuretics before the surgery. Preoperatively, we should stop the diuretics.
Okay.
The patient may have
Electrolyte
presentation of
imbalance.
dehydration and
Which
electrolyte
electrolyte
imbalance.
imbalance will be there? Is it all electrolytes or specific electrolytes?
Potassium. Booster.
Potassium, will it decrease or increase?
Hypo.
Some diuretics will decrease the potassium, like loop diuretics, thiazide diuretics, all will cause excretion of potassium and patient may be hypokalemic.
Hypokalemia.
Whereas if you use aldactone, potassium sparing diuretic or
spironolactone,
they may have hypercalcemia, hyperpotassium. Okay. So thiazide and loop diuretics are not potassium sparing, so it may cause hypokalemia with metabolic acidosis. On the contrary, potassium sparing agents may produce hyperkalemia. And diuretics usually dehydrate the patient. So patient may be volume depleted. And thiazide diuretics may aggravate glucose control, especially in combination with beta blockers. And thiazide diuretics may prolong neuromuscular blockade with non-depolarizing muscle blocking agents. And many long-term hypertensive patients have a masked state of hypovolemia. So soon after induction, they will have a sudden hypotension. So you have to hydrate them adequately before induction. What are the anesthetic implications of angiotensin and converting enzyme inhibitors?
should be stopped preoperatively.
Why?
There will be hyperkalemic presentation in these patients.
Somebody mentioned it should be stopped preoperatively. What is the reason? Why do you want to stop it?
So
Because it
they
is
can
given
be
to
refractory
control
Renal artery hypertension causes renal artery stenosis.
The protective mechanism will be lost.
Is it caused by ACE? Renal artery stenosis is a abnormality of the vessel. Will it cause so much constriction of the vessel? It only prevents the conversion of angiotensin at the lung level. ACE inhibitors acting is at that level, isn't it? It is present in the lung normally. So when you block it, the angiotensin 1 is not converted to angiotensin 2. So angiotensin 2 is not available, vasoconstriction cannot happen. So there is a vasodilatation. It can produce refractory vasodilatation. So that is a risk, increased risk of refractory hypotension. Angioedema, of course, this known effect. If that would have happened preoperatively if you have used that. So how is the angioedema caused by ACE treated? We found earlier itself, I told you it is not because of histamine release and it is due to bradykinin. So how do you treat histamine released angioneurotic edema? What is the treatment of acute angioneurotic edema caused by histamine release like in anaphylaxis?
Steroids.
The use of adrenaline.
First drug to be given.
Adrenaline.
Should be adrenaline, either subcutaneous or intravenous as the first line of drug. Then steroids to control the edema, fluids and supports. Okay, that is the treatment. Whereas for angioedema caused by ACE, will this work? Because it is not caused by histamine. So you have to block the effect of bradykinin. So bradykinin receptor drugs are available nowadays, and it is called icatibant or kallikrein inhibitors. Icalantide may provide novel alternatives to the treatment of ACE-induced angioedema. Okay. How is the refractory hypotension caused by ACE treated? Supposing you don't take proper history, patient is taking some ACE inhibitors for a long time, and you give a spinal for a fracture or lower limb procedure, and the patient goes, BP suddenly drops. How will you treat that?
Try to go for vasoactive agents.
Just say the correct drug name. Vasoactive agents, there are so many drugs, isn't it? Which particular drug is
Inotropes, we use ephedrine, phenylephrine.
Or
phenylephrine and ephedrine are the common drugs that you use, but will they respond to the drug?
No.
It is refractory. For any spinal hypertension, our first choice is either ephedrine or phenylephrine. But if that doesn't work, which drug will you prefer?
Vasopressin.
So if the traditional vasopressor options such like phenylephrine and ephedrine without desired clinical effect, then go for vasopressin, epinephrine or norepinephrine. Okay, these are the three drugs which are preferred for treatment of refractory hypertension. And because in those conditions, these commonly used drugs won't work. Phenylephrine, ephedrine may not have the desired effect. So always keep vasopressin, epinephrine and norepinephrine ready and start them at the earliest. After one dose of phenylephrine or epinephrine, if there is ephedrine, if there is no response, don't repeat and waste time. Go immediately for these drugs to treat the hypertension. If the patient has knowingly or unknowingly continued AC inhibitors before surgery and no instructions have been given to stop the drug. Okay, so that is what you have to remember with that. So that closes the discussion on all this cardiovascular system. Instead of blindly talking about physiology only, I thought of combining all physiology, anatomy, pharmacology concerned with each system. So that is the approach I thought will be more useful. So any questions or any doubts on this?
No, sir.
Okay. Right. If you are all happy with the presentation that made, then next class will be the basics of nervous system and relevant to anesthesia. Okay. So that is
Okay,
what
sir.
I'm planning to discuss next week. After that, it will be
Yes.
basics of gastrointestinal system, renal system, then gastrointestinal system. So we have completed respiratory, we have completed CVS. Next important system will be CN and nervous system, both central and peripheral nervous system. Commonly asked theory questions also will be discussed in that. Then we will go for renal physiology, anatomy, and concern the topics with renal system and anesthesia. Then gastrointestinal, because nausea, vomiting is a very important part of our anesthesia management. So we will go for the discussion, and so that will complete all the basic sciences. Of course, neuromuscular physiology, neuromuscular transmission also will be included in one of these things. So with that, we complete all the basic sciences topic because it includes, this discussion includes all anatomy, physiology and pharmacology. So we need not have to allot classes separately for each and every one. Okay. So that way we will discuss and complete the basic sciences in the future. Is my plan. Okay. If it is agreeable to all of you, please go through
Yes,
this
sir.
topic, go through the nervous system topics in the next class. We are starting from anatomy, physiology, and pharmacology. Okay, and we will discuss that in the next classes.
Yes. Thank you so
Thank
much,
you.
sir. Thank you.
Thank you.
Yes, sir.
Thank you.
Thank you very much, sir. The class was very elaborate and very detailed, sir. It was very useful. And the pattern it was
I
presented in
just
15
wanted
minutes.
to add some of the newer drugs and newer things which are
Yes, sir. Yes, sir.
being practiced nowadays in more frequently by the cardiologists and other specialty people. So I thought our students should be aware of the newer drugs that are being frequently prescribed and their effects and interaction
Yes.
with our anesthesia practice.
Sir, and I have one small request, sir. Can we include hematology also in the basics, sir? Because nowadays, our after COVID, the vascular events are on the rise, sir. And most of the patients are presenting with vascular catastrophes. So
Okay.
it's good that our anesthesiology postgraduates are aware of the hematological drugs with which the patients can come to us.
That comes as a complication of a particular disease, isn't it? All the
Yes, sir.
presentations.
General
post
coagulation,
COVID.
yes, sir. Hemostasis physiology can be discussed, sir. And relevant pharmacology.
Yeah, and iron deficiency anemia, and that's a common clinical case presentation that is kept in the exam also. So
Yes,
if you
sir.
want discussion on hematology, we have to discuss coagulation as well as the anemia and iron and
Yes, sir.
abnormal
That's it.
globinopathies, all that has to be discussed.
Yes, sir. And fluid management and health plates also, sir.
Blood and blood products.
Okay. So you can plan.
Yes, sir.
Okay. Good evening, Vasanti.
Madam, good evening,
Sir,
madam.
good evening, sir. Sorry, sir.
Nice to see you after a long
I just wanted to hear your voice, sir.
Very, very nice of you. Thank you.
Sorry, sir.
Very good, right? Thank you. Nice.
Okay, sir.
Thank you, madam. Thank you.
All those who are members of ISA, please vote before the 5th. If you are already a member in the Society of Anesthesia, elections are going on. So please cast your vote before the 5th. And, do your duty as a member of the ISA. Those who are post DA students may be members in ISA, so please don't forget to vote before the end of 5th 5 p.m. is the deadline. Please cast your vote and do your duty for the society. Thank you very much. Good night.
Thank you, sir.
Thank you, sir. Thank you very much, madam.
Thank you.
dear
Thank you,
students.
sir.
We'll meet again next week. Thank you.
Thank
Thank
you.
you.
Shall I sign off this meeting?
Yes, sir.
Yeah,
Yes, sir.
okay. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.